Important safety information. Indications and usage. Ceriana is a radioactive diagnostic agent indicated for use with positron emission tomography, PET, imaging for the detection of estrogen receptor, ER, positive lesions as an adjunct to biopsy in patients with recurrent or metastatic breast cancer. Limitations of use. Tissue biopsy should be used to confirm recurrence of breast cancer and to verify ER status by pathology. Ceriana is not useful for imaging other receptors, such as human epidermal growth factor receptor 2, HER2, and the progesterone receptor, PR. Important safety information. Contraindications. None. Adverse reactions. In clinical trials evaluating the safety of Ceriana in patients with breast cancer, N equals 1,207, the following adverse reactions occurred at a rate less than 1%: injection site pain and dysgeusia. To report suspected adverse reactions, contact Ceriana U.S. Corporation, a GE healthcare company, at +1 800 654 0118 or FDA at 1-800-FDA-1088 or www.fda.gov/medwatch. For full prescribing information, visit http://ceriana.com/PI.
I'm going to talk about the uncovering the unmet needs in breast cancer. So I'm a breast cancer specialist. I only know how to treat breast cancer. And often the time, it's in my practice, and I wish I have more tools and I wish I have more medications. We all have those patients. Sometimes we're kind of attached to them and we just don't have a lot of tools. So I'm going to talk about one of the unmet needs in breast cancer tonight. And when I have a breast cancer patient, my first reaction is always, what's the ER status? What's the HER2 status, right? That's the most basic questions I have for any patients with breast cancer. So because it guides clinical decisions, nowadays we are so heavily depending on the biology, and we always want to know the ER status, HER2 status before even we talk about the options to any patients. And often the time in oncology, when a patient presents with stage 4 metastatic cancer, biopsy is a gold standard for us to know, is this truly a breast cancer, and is this ER positive or this is ER negative? But often the time, I don't even know how many times we run into the issue that when I was even a resident, the most common phrase I was told was, tissue is always the issue, right? We always have that issue. And sometimes it is really difficult to biopsy, and sometimes the patient may decline biopsy, and sometimes the patient can have multiple lesions, and we can know status of one lesion, but we cannot know the status of all the lesions. So often the time we make decisions based on the primary breast cancer or a single location biopsy, knowing that it may not be representative of the ER status of the entire body. So this is one of the unmet need that often the time I run into problems in my practice. So, and we all know, and we all run into these problems that the ER status can change in the same lesion or in different lesions. So often the time, the ER expression can be discordant between different lesions at the same time, or even it's the same lesion change over time in the same patient. And that percentage can be high, up to about 30%. So, and also specifically for patient with metastatic breast cancer, lack of estrogen expression change the recommendation, right? The endocrine therapy is no longer the choice of agent. So for that good reason, knowing the ER status is so important in managing a ER positive metastatic breast cancer patients. So just to summarize the unmet need we have here, ER positive breast cancer is very common. More than 70% of the tumors would have the ER status, but not all the patients respond to endocrine therapy. And even some patients respond to the treatment initially, they can become refractory. And we all have those patients, and we have to switch them to chemotherapy later. And also, some patients have unpredictable response, and they can acquire resistance to endocrine therapy. And that can be because the tumor has ER discordance. Even we happen to biopsy one lesion that was ER positive, but it's possible other lesions that we did not biopsy, and it could be ER negative, and it happens. So because the ER discordance in the same patient, so often the time a single biopsy we may or may not be able to get does not represent the ER status of the whole body. And also, the ER expression of a patient disease may change naturally over time or following treatment. So I have quite some patients following the ER status start with 99%, slowly drop to 80%, 60%, eventually negative. So often the time it is so important for us to stay on top of that and make sure we are offering the most effective and appropriate treatment. So for that reason, make sure we clarify the extent of ER discordance in the same patient can be very important for us. So luckily, we have the FES PET available now. So I have the luxury that when I was in training, I participated in the FES PET CT early development, and I had the luxury. I have awesome radiologists. So as soon as it's available, we already have the tool in our institute. So I already have the luxury to use FES PET for over a year, and I had quite some good experience to share. So what is the FES and what is Ceriana agent? So it's actually a radiation labeled estradiol. And those radiation labeled estradiol has very high affinity to the estrogen receptor. So it binds to the estrogen receptor with really good affinity. And in some earlier literature we did, it is 100%. So they are very effective, high affinity, and good look for the estrogen receptor. In that way, when you do the PET CT, any lesion express estrogen receptor would light up on the FES PET. So when we do the imaging interpretation, we always need to be aware of the normal physiologic distribution. For instance, for the regular FDG PET, we all know we don't even look at the brain, right? It has a very high physiologic distribution. And so for the FES PET, it's quite different in the way that we do not have a lot of ER in our brain tissue. So actually the brain expressed very well, does not have a whole lot of background. But for the liver, liver is the place where the estradiol is being metabolized. So often the time we may have a high background in liver, and it is eliminated by the biliary and urinary excretion. So in that way, you see the bladder would light up, and also the bowel, the biliary tract may light up. And the uptake time is pretty good, 20 to 80 minutes. Typically, it's about 80 minutes. This is more for the radiologist, and typically the radiologists take care of all that. I know we have radiologists today too. And what's the difference between the FDG PET and FES PET? So for the regular FDG PET, we have been using the two for years, and it is very well known that we don't even try to look into the brain, right? We have very high metabolite in the brain, and it would have a very high background. And also it is important to know that it has nothing to do with your hormone receptor analysis. It's sugar, right? Any tissue take up sugar faster would light up on the skin. And I don't even know how many times we discuss patients at the tumor board, and specifically for patients with indolent tumor, such as lobular carcinoma, when the PET, regular FDG PET was negative. And are we 100% assured? Probably not. It is very well known the lobular carcinoma does not show up on the regular FDG PET very well. It's a very well-known phenomenon. On the other hand, FES PET is radiation labeled estradiol. So first of all, the brain tissue actually show up very well, and also give me information on the estrogen receptor. And on top of that, on the indolent tumor, such as lobular carcinoma, the FES PET, because of the high affinity, and it shows up on the FES PET better in our hands and in some clinical studies. So those are the differences between the two scans. This is just kind of showing a picture that how different a regular FDG PET and FES PET. So this is a publication published to tell you the difference between the regular FDG PET and FDG PET. So patient 1 is a typical patient with metastatic ER-positive breast cancer, had treatment by aromatase inhibitor and a CDK4/6 inhibitor. So we call this patient 1 a responder. If you look at the pre-treatment scan, the patient has quite axillary lymph nodes, quite some spinal mats. Of course, if you look at the difference, the regular FDG PET, the brain does not show up, and the regular, the FES PET, the brain, actually, we have a very clear picture. Of course, the liver has a very high background. And 8 weeks later, we repeat a PET scan. You see the patient respond to the treatment very well, and all the lesions showed up on the FES PET. So this is a perfect example. FES was actually able to tell us what's the ER status of the lesions. Patient 2, however, we called a non-responder because the patient actually did not respond to the treatment. And if you look at the baseline FDG PET and FES PET, you see the patient has a lot of spinal lesions on the regular FDG PET. But if you look at the FES PET, most of the lesions did not even show, and they were not even FES avid. So not surprisingly, 8 weeks later, when you repeat the scan, the patient actually did not have much response at all. So this is one of the examples that the FES PET not only give you information on one lesion, the ER status, it gives you the ER status of the entire body. And another question often came up would be, well, the estradiol radiation labeled will go bind with the estrogen receptor. What if the patient is already on treatment? Would that interfere with the sensitivity of the scan? So there are quite a few different drugs, and it's quite a different scenarios. So for SERMs like tamoxifen, the half-life is about 7 to 10 days. So for that reason, to make sure it does not interfere with the estrogen receptor binding. So 8 weeks was recommended. And third, such as fulvestrant, of course, the half-life is even longer. So for that reason, a longer drug-free duration is being recommended. So I just want to point it out that for aromatase inhibitors, a lot of our patients in the stage 4 setting are on aromatase inhibitors. They have nothing to do with the estrogen receptor binding. So for that good reason, we do not need to hold off aromatase inhibitors just to have a FES PET. So again, I just want to emphasize that often the time, even one lesion in the body is ER positive, and we don't know for sure if all the lesions in the body would be ER positive. For that good reason, the FES PET CT gave me a non-invasive assessment of the whole body ER status, and often the time it can be very useful in the clinical setting. So, and there are clinical evidence how good the test is. And there are quite some studies looking to the positive agreement and negative agreement. So quite some studies, and in general, the positive agreement would be anywhere 76 to 80%. So another word, about 80% of the ER positive lesion would be picked up by the FES PET. And there were about 20% of the lesions did not pick up very well on the FES PET. And also, this is another data to support that it's somewhere around 76 to 80%, and the specificity is 98 to 100%. And often the time we have clinical dilemmas, right? We did all the routine workup, CT, MI, FDG PET. I have a case to share later too, that we still are not sure what is going on with the patient. So we call it clinical dilemmas. This is a very good study did by the Dutch folks that they look into the clinical dilemmas. So the physicians will answer the questionnaire right before they order the scan, right after they order the scan, and quite a few months later, and they have to answer the question again. So out of the 100 FES PET was performed, 80% of the time, the clinical dilemmas were resolved. That actually goes along very well with my clinical practice. When I order the FES PET, and often the time I have a question, and about 90% of the time I felt my question was answered. And out of that 87 FES PET, more than 90% led to a treatment decision. Because what my training has been, you don't order a test just for fun, just to know, right? You're ordering the scan because you want to make a decision and you need the information to make decisions. So, and when it comes to lobular carcinoma, and our breast cancer field, and often the time, how I say that is lobular is evil. It's so unpredictable, right? It doesn't follow your gut feeling. It does whatever it wants to do. So it is actually the second most common breast cancer subtype. And it is very well known that most of the lobular carcinoma are hormone receptor positive. About 95% would be ER positive. And in general, it has a higher rate of distant recurrence. And it doesn't show up on the FDG PET very well. So often the time, it is important for us to identify those patients and be aware of that. So FES actually, in my hands, and also in this study, it is more sensitive to detect metastatic lobular carcinoma lesions. And I had full empathy for the radiologists who did this study. They have to measure 268 osseous lesions. And if you look at all those lesions, and 94% was FES avid, and they would let up on the FES PET, but only 34% were FDG avid. So just to summarize, I feel fortunate that we have this molecular imaging in oncology nowadays to help with the decision. And the ER targeted imaging is FDA approved, and it's a very unique tool in my practice to help me with decisions. And for me, again, I'm not ordering FES PET for every single patient walking to my door, right? So I order the scan when I have a question, when I have clinical scenarios. So one, when the patient has really difficult to biopsy lesions or patient declined biopsies, and the two helps, the imaging help me, or they are difficult to detect lesions when it's lobular carcinoma, or when I need to see if a patient is eligible for clinical trial. The last would be when I run into clinical dilemmas, when there are patients that I do not feel any conventional imaging can help me. Often the time, this imaging tool help me.
Disclaimer. This presentation and all information, content, and material therein, without limitation, is for informational purposes only and is the intellectual property of Xianexa US Corporation, a GE healthcare company, not for publication or further distribution. Do not copy or share without express permission from GE Healthcare. Information communicated during this presentation is intended in good faith to be truthful and non-misleading and presented with fair balance. It is not medical or professional advice provided by the sponsors, hosts, and presenters of the webinar. Professional medical judgment should be exercised before any action is taken in relation to information presented herein. All the sponsors, hosts, and presenters' rights are expressly reserved. Images and videos used in this presentation, unless otherwise indicated, are used with permission from the Swedish Medical Center and obtained in accordance with all applicable laws. Dr. Yan is a paid consultant for GE Healthcare and is being compensated for this presentation. Please contact GE Healthcare directly for further information about this presentation or Ceriana.